Welcome, everyone. This is Dr. Sharad Jaitly, your cardiologist from New York, on your favorite website, MuniMeterHealth.com, which is dedicated in educating and teaching you about the human heart and its illnesses across the globe on our social media channels. I thank you for your enthusiastic interest and support that you have given to me in forwarding and fostering my interest and spreading this knowledge freely to all. Once again, thank you for being on MuniMeterHealth.com and come in one and all and associating with our website for this knowledge. Without any further ado, I'd like to delve into the subject matter. And the matter of the subject being today is, what is contrast echo? Now, we heard about echo in my previous videos. We heard about stress echoes in our previous videos. I'm sure you enjoyed watching and learning on it. So what is contrast echo? Now, contrast echo, the number one indication is when you cannot actually get a transthoracic echo window in an optimal way. If it's suboptimal, in other words. So the moment you have a suboptimal window, you're not able to see the left ventricular function, perhaps. You're not able to see any, obviously you're not going to see any shunts unless it's really, prominent shunt where you can see a color Doppler. So specifically the smaller shunts can be missed. So the LV visualization, so that's one of the things that I always say. Many times you would like to see what a right to left shunt is, if you will. And that's the classic example would be PFO, and which is patent foramen ovale. Now that obviously, and I'll show it to you into our little schematic as soon as I get a chance. So which exists right between the right atrium and left atrium, and could be responsible for several what you may call paradoxical embolisms, or even right to left shunts. People are very worried about how the infection traverses on the left side. Should there be any air embolisms, for instance, that can occur, or fat embolisms that can occur. So PFO is a very, very important entity, and that needs to be sort of visualized and ascertained in your diagnosis. And 3, you'd like to see what the LV, say, perfusion pattern is, or if you wanted to see the LV wall motions, for instance, wall motion abnormalities, we call it WMA. So these are some of your indications where one sees all of this going on. Now let's move on to our schematic, our favorite schematic here. And our favorite schematic will show, say, if this is your heart, and I'm drawing it just like as it's sitting in your chest first, and then we'll go on to the echo image. Here is your left ventricle, obviously, the RV, and then the RA on the top and LA on the top, right? So as a result, what happens is there is a small aperture that tends to develop, which is present normally at birth, actually. And if that fails to close, and that's called the patent foramen ovale. So the right to left shunt will occur in this fashion. It's a very small, almost like an ASD type of, not an ASD, but actually a small aperture which is normally present. And normally, because as the left atrial pressures start to rise when the child is born, this flap will close, and therefore the foramen ovale closes. It's not staying patent. But if it stays patent for whatever reasons, whether it fails to flap back, or right atrial pressures tend to exist even higher for a longer time, or the left atrial pressures are weaker, or there is a missing flap on top of it, so by congenital absence of it. So one tends to see this right to left shunt persist throughout the life. So obviously, you have a tendency for, say, if there was a DVT, for instance. Now, a DVT, I'm just giving an example, deep vein thrombosis in the legs. Obviously, it'll traverse back into your inferior vena cava somewhere here, for instance, and this being the superior vena cava here. This is your SVC, and this is your IVC. So when it traverses here, the thrombus may actually dislodge and traverse in through the right to the left shunt and lead to paradoxical embolism, as we call it. Okay, so paradoxical implying that normally it's on the left side, but this is a right-sided thrombus which traveled to the left side paradoxically, and therefore bypassing the entire lung circuit, if you will, and that leads into systemic embolism, we call it, or it can manifest as a CVA, it can manifest as renal infarcts or renal embolism, renal infarcts we call it, or it can manifest even as splanchnic infarcts, etc. So, patent foramen ovale is a very, very interesting or intriguing entity, and clinical entity must be seen. Now, let's get to so having defined what is patent foramen ovale, let's come back to the contrast echo, because that's the focus of this video. So here is your famous view, which is called the apical view. And when you have an apical view like that, you have your heart. We'll draw it in the red, if you will. Yeah, let's draw it in the red. So this way, this is your RV, and we're drawing your RV here first, and then we draw your LV here like that, and then we draw your LA here. So RA, LA, RV, and LV. As you know, just for the sake of the medical students, I'm sure the residents and fellows, they already know, the heart is actually invertedly represented on a 2D echo view. Remember that. It's not the true view in the chest, but that's how it's represented. So this becomes your apex, and this is your base of the heart. So A and B. So 2D apical view or 4-chamber apical view will only have a similar pattern. Now, obviously, the shunt will be present where? Between the right atrium and the left atrium. So here, assuming that this is your patent foramen ovale, so the shunt will traverse in this direction. So now, if you start to, now what is contrast echo? Contrast echo, the principle behind is that the micro bubbles that are traversing through the blood stream from a saline agitated contrast, for instance, if you just agitate, say, 5 to 10 ml of normal saline in a syringe and then just inject it abruptly through a 3-way cannula, which is in your antecubital vein, the chances are this contrast will start to, now we'll show the contrast here, how it fills up. The contrast will start to fill up like this first in the RA and then go into the RV. Why? Because obviously it's coming from the inferior vena cava or superior vena cava, depending upon where you're injecting, mostly from the superior vena cava. So as it comes in, the contrast will. Now, simultaneously, if it starts to show up here into the left atrium, now that clinches the diagnosis of right to left shunt. What have you diagnosed right away? In a matter of few seconds, as soon as you inject the agitated saline, via the intravenous fluid, and all it takes is 7 to 10 cc's of abruptly pushed IV saline to go in, and those microbubbles that will form and form a specific contrast. Remember, the whole principle of echo or 2D echo is based on how the various medium, if you will, or media, they contrast from one to the other. So therefore, we can delineate the walls, for instance, we can delineate the valves, we can delineate the blood, the cavity, etc., based on each time there is an interface change from one medium to the other. So same principle is being utilized for the contrast. Now here you have agitated bubbles going in there. And what are these bubbles? They are gas bubbles. And gas is extremely lighter than the blood. And therefore what happens is you have this, obviously lighter in the sense that it's dense, it's less dense. And it's 100,000 times dense if you were actually to look at it. It's between the blood, the saline gas bubbles, and the blood, the ratio is 1 to 100,000 almost. So that is the ratio in between the density. So the gas is obviously so light that it's 100,000 times lighter. So there will be enough contrast between the RA and the RV right away that will be seen. But if it starts showing up on the LA, you know that there is a right to left shunt existing. Now later on, yes, after the circulation traverses through the pulmonary vasculature, some of these microbubbles will appear in the LA and then into the LV. But that is a different type of contrast one starts seeing later on, but that develops later. But if you see it spontaneously, as soon as it shows up in the RA and then you have it in the LA, the chances are that there is a right to left shunt, and you can indicate further studies like transesophageal echoes, etc. later on, or clinch the diagnosis of PFO right there, and then you can actually measure the magnitude of the right to left shunt as well. So this is the essential principle, and the same is true with the wall motion abnormalities, because with the contrast echo now we start seeing if there is a wall motion abnormality that is existing. So you will be able to see in the left ventricle specifically if some portions of the wall is not moving, if the other portion is hyperactive, or this portion is inactive, etc., etc. So depending upon whether you see akinesia, whether you see dyskinesia, or whether you can see hypokinesia, depending upon the kind of wall motions abnormality that exists in these individuals, specifically in the chronic ischemic heart disease and in the myocardial infarction cases. So, in a nutshell, I just want to quickly summarize that right to left shunt has been a very, very important entity, and that has been so far seen to actually show different kinds of shunts. So the contrast echo utilizes obviously huge evidence of, let me just X out here, with this showing up on my screen for some reason. And okay, so the contrast echo utilizes the interaction of the microscopic gas bubbles, as I said, with ultrasound to enhance the recognition of the blood pool. The principal use, obviously, between
in the obviously folder,
and the found is. Let's see here, we X this out here, for instance. And utilizing air bubbles produced by the agitation of saline in the recognition of intracardiac shunting. And so particularly specifically so PFO is the interrogation of the clinical entity. And to contrast agents, again, utilizing you can combine that with harmonic imaging, and we'll talk about that in a different setting. And left ventricular opacification, specifically so if you wanted to see the wall motion abnormalities. And then likewise, you'd like to see if you can actually assess further tools to develop contrast, because again, remember, this contrast echo is still in the offing and it's not totally developed, but this was in a nutshell. So I appreciate your interest in understanding what contrast echo briefly is. It's obviously utilized when the transthoracic windows are suboptimal, right to left shunt in a setting of PFO, left perfusion studies specifically for stress echoes if you wanted to see the wall motion abnormalities in a setting of chronic ischemic heart disease, to ascertain if there is any myocardial perfusion viability present, because perfusion goes along with viability, as you know, and things like that. So paradoxical embolism, specifically if you're investigating the cause, PFO may be one of the culprits that's commonly not seen on a routine transthoracic or even transesophageal, but a contrast echo will help delineate that. I thank you for your interest, and again, keep watching MuniMeterHealth.com, your favorite website. And so long, this is Dr. Sharad.